to our webinar entitled AASLD Update, the advancing role of non-invasive testing in NAFLD-NASH. Today's webinar is brought to you by Echosens North America, the inventors, manufacturers, and suppliers of the FibroScan technology. I am Jerry Mayberry, your host for today's event. As a reminder, all participants are muted to assure good sound quality during the presentation. Please submit any questions to the question and answer panel on the left side of your screen. After the presentation is completed, the submitted questions will be read to Dr. Harrison. This webinar includes information on the uses of the FibroScan technology from the published literature. Echosens does not intend to make any specific claims found in this presentation. The FibroScan device is FDA cleared as an aid to the diagnosis and monitoring of patients with liver disease and is used as a part of an overall assessment of the liver. It is not intended for the treatment of any specific liver disease or condition. Today's presenter is Dr. Stephen Harrison, a world-renowned expert in the field of fatty liver disease. For those of you who may not know Dr. Harrison, he completed his internal medicine residency and gastroenterology fellowship at Brooke Army Hospital and subsequently completed an advanced liver disease fellowship at St. Louis University. Dr. Harrison is the past associate editor of hepatology and is currently the associate editor of alimentary pharmacology and therapeutics. Dr. Harrison serves as a peer reviewer in numerous peer-reviewed journals and is an internationally known thought leader in the field of NAFLD-NASH. And now I would like to turn the microphone over to Dr. Harrison for his presentation. Dr. Harrison.
Hey, thanks, Jerry. I appreciate that. And thanks to all those who have chimed in today, either over your lunch break, before, or just after your lunch. Happy to talk to you today, give you a little bit of an update, what we came out of AASLD learning, particularly as it pertains to non-invasive tests, but also a little bit of data today on healthcare economics as it pertains to fatty liver disease. There were some pretty exciting abstracts that were presented and subsequently are going to be written up and published here pretty quickly related to healthcare utilization in patients with fatty liver and particularly those with more advanced disease. So some exciting pieces of data to talk about today. I want to try to get through this in about 40 minutes and open the floor for Q&A, and hopefully it'll be well worth your time to join in. So without further ado, I'm going to just jump right in to where we wanted to talk. And the first one is just to set the stage and remind you that fatty liver is a continuum that ultimately is what we call an umbrella term. Non-alcoholic fatty liver disease really encompasses isolated steatosis through steatohepatitis and into cirrhosis and even liver cancer. And often people get the term NAFLD and NASH confused. Really, for the purposes of my talk today, I'm going to use NAFLD to infer anything that doesn't quite reach NASH. So, isolated steatosis with mild inflammation, and then just separate and distinct will be non-alcoholic steatohepatitis and its subsequent progression to cirrhosis. So, just a brief history on natural history. Most people, about 80% of people with fatty liver, will have isolated fatty liver or fatty liver with mild inflammation, and these guys are going to have really very minimal progression to fibrosis. I was at a meeting in Fresno, California, Monday night, and Nora Thoreau gave this part of the talk on fatty liver, and she showed a very elegant slide showing about 3% of people with isolated fatty liver in the recent literature will progress. So it's still very, very small. I think most of those people actually have some mild inflammation, and as I'll show you in a moment, those may be misclassified. In fact, they may actually have NASH, but you didn't pick up ballooned hepatocytes, which is the pathognomonic signature hallmark lesion of NASH where you have a apoptotic cell that's basically undergoing programmed cell death. So we often will miss ballooning, but we'll see lots of inflammation and hepatocellular unrest, and we think those are probably NASH patients. We just didn't get the enough tissue to find the balloon cell. Having said that, if you do have NASH, and this is 20 to 25% of fatty liver patients, there is increased risk of death, and it's mainly cardiovascular, non-liver related malignancy, and then liver-related causes of death. What we do know is that NASH with fibrosis portends a worse prognosis, so a little moniker there you can throw in the back of your head. We know fibrosis progression is associated with diabetes. In fact, about 40% of diabetics have NASH. We know that increasing weight gain and rising ALT are actually predictive of progressive liver disease. So, who progresses to cirrhosis? It's highly variable, but about 10 to 11% of patients with NASH will progress over 15 years. We know that diabetes increases the rate of progression, as does a rising ALT level. And then about 1/3 of patients will decompensate over the next 8 years, and some people will go on to develop hepatocellular carcinoma. The sobering statistic is that you don't have to go through a NASH phenotype to get to liver cancer, and this tends to be accentuated in the Asian population, where about 50% of patients actually that have liver cancer have either NAFLD or NASH with mild degrees of fibrosis. So bringing it a little bit closer to home, I wanted to share with you some data that's not yet been published, but it's a study we recently wrapped up, and I'm showing you data from 532 patients that were prospectively evaluated at Brooke Army Medical Center when they presented for routine colon cancer screening. Every patient in this list thought they had a healthy liver. They had no history of liver disease and did not consume alcohol that would put them at risk for alcoholic liver disease, and they didn't take medications that caused fatty liver. You see the mean age is 56, which is representative of a population presenting for routine colon cancer screening. They were obese, half were male, half female. About 14% of patients were diabetic, which is relatively representative of the prevalence of diabetes in this patient population of a mean age of 56. And we did a plethora of imaging studies on these people after they signed consent. They obtained a FibroScan with controlled attenuation parameter, or CAP. They had a liver multiscan, or what we call corrected T1 image done on their liver. And they had an MR elastography done, and they also had MRI proton density fat fraction done on them. Now, if you look at the prevalence of NASH in the entire population of 532 patients, it's 33%, which is not inconsistent with what's published in the literature. If you look at the recent review article written by Zobair Yonasi, that paper says 25% of U.S. population has fatty liver, but that's kind of all comers. If you focus in on the 56-year-old population or the middle-aged population, it's a little higher at 33%. Now, this is the next line, NASH prevalence. This is where it really gets scary, because we found the prevalence of NASH to be almost 18% in this population of patients. The quoted literature is 3 to 5%. Now, granted, that's all comers, and we know people in their lower 20s or teens don't have as high a prevalence as patients in their 50s, 60s, and 70s. We also know there's a drop-off in prevalence in the 80s and 90s. However, this is a sobering statistic, and it actually comes to us as the only prospectively obtained prevalence number in the world. There's no other study you can look at that prospectively has defined the prevalence of NASH with liver biopsy. So this is what we have to go on, and so this is what I believe to be true. Now, if we focus on the patients that had NASH on liver biopsy, some interesting statistics pop out. On this pie chart, you see 19% of patients had no fibrosis, 46% had mild disease. So ultimately 64% or 65% of the patients had mild fibrosis or no fibrosis. But maybe just as interesting to me, a third of patients had F2 to F3 disease. Now remember, these are people that came in thinking their livers were completely normal. And a third of them, it turns out, that had NASH had moderate to advanced liver disease. So that was interesting to find out. And then if you look at the bar graphs to the right, and this is titled the percentage of type 2 diabetes in NASH patients, you see that percentage rises significantly between F2 and F3 patients, such that the majority of my F3 patients, the majority of the 11% of F3 patients actually had diabetes. And so this is where we get some of the data to suggest that the progression of fibrosis in NASH is driven in large part to diabetes. Now, so let's move on and talk about diabetes trends. We know that diabetes is continuing to increase in our population. And on the vertical axis, on the left-hand graph, you see U.S. diagnosed diabetes in millions of patients. In 2010, it's around 20 million. In 2020, it's projected to be conservatively 30 million. And then by 2030, almost 40 million. And that's conservative estimate. Obviously, aggressive estimates are much higher. When we look on the right-hand graph with obesity trends, of course, the U.S. leads the way. That's the red line moving up to the right, and that's at the top. Right behind that is England, and then catching up very quickly is Australia, and then you see all the way down where Korea actually is rising, but it's the least prevalent amongst all the countries assessed here today. So what about liver transplantation? And I put this slide in here because there are some out there that still believe NASH is not a disease. That, they've treated docs have treated diabetes for years and years, and they've never seen patients develop liver complications. Well, this data suggests otherwise. And NASH is in the red line. Hep C is in the top dashed line. And ultimately, alcohol is kind of in the circles in the middle. And what you see, at least in this published literature from Surgery in 2014, is that NASH is on the rise, Hep C is falling, and it's projected that by 2020, NASH will become the #1 reason for liver transplant. Now, interestingly, alcohol, if you look at other data sets, is actually increasing as a reason for transplant as well. And this is thought to be tied to the opioid epidemic that's currently ongoing. So what about liver cancer? I alluded to that in my natural history slide, so I wanted to bring focus to this today and really just speak briefly to what we know. And I want to focus down on the bottom right-hand graph. And here, look at the orange part of the bars. The orange bars represent NAFLD patients. And across the horizontal axis is year 2000 to 2010, and the vertical axis is number of referrals with liver cancer. And what you see is early on, prior to 2003, there were no referrals for liver cancer where the patient had fatty liver. But by 2010, the majority of referrals are actually patients with fatty liver. And then if we shift back over to the two studies on the left, both of these studies come from Asia, and it just highlights the fact that you can get liver cancer outside of a cirrhotic platform. So what about NAFLD-NASH from a diagnostic perspective? Well, liver biopsy is still king. You can't make a diagnosis of NASH without it because we don't have a test that's very sensitive for detecting ballooning degeneration, which we know is the histopathologic hallmark of this disease. But is a liver biopsy always necessary? I think we all agree it's not. However, it does remain necessary and useful in certain situations. That would be to confirm the diagnosis and exclude additional comorbid illnesses in the liver. So I'm in clinic today, and this morning before this talk, I saw a patient that had autoimmune hepatitis and fatty liver. and that was made on a liver biopsy. We can also stage the disease and stratify progression risk, and then we can tailor this biopsy to patients that have marked biochemical abnormalities on LFTs, if there's diagnostic doubt, or if non-invasive scores like the FIB-4 and the NAFLD fibrosis score are high or they fall in the indeterminate range. And then finally, sometimes patients just want to know. So what we're going to talk about throughout the rest of this presentation is how do we select patients for liver biopsy and exclude those who have low risk of disease and don't need to be put through that undue risk of a biopsy. So I wanted to give you some context of what NASH looks like on a slide. And this is an H&E slide in the purple on the right and a trichrome slide on the left. And the trichrome slide highlights fibrosis that you see in the light blue. And then on the right, the H&E stain highlights fat and inflammation. So the first thing I want to show you is steatosis. And these are the little white globules that you see, and they are basically triglyceride. So this disease really comes about through what we call insulin resistance. And in insulin-resistant states, adipocytes, or fat cells in the periphery, secrete inappropriately fatty acids, free fatty acids. And those free fatty acids get taken up by the liver, and they're very toxic. So the liver does two things right away. It either burns them through fatty acid beta oxidation, or it esterifies them into triglycerides and stores them as these inert fatty globules that you see showing up on the slide. So that's what steatosis looks like. Now, ballooning is what you see here, where the red arrow is highlighting this cell that's quite large. You see this nucleus is pushed to the edge here, this black dot, and you see this purple, pink, ropey cytoplasm in the middle that we call Mallory dink bodies or Mallory's hyaline. Now, this represents a cell that is dying. It's undergoing programmed cell death. And when that happens, you get a significant release of inflammatory mediators that trigger a cascade effect that ultimately results in stimulation of what we call stellate cells. And stellate cells are responsible for laying down collagen. And that shows up in blue, and I'll show you that right here. I'm going to skip over inflammation, come back to it. This blue collagen you see here around the portal tract, but you also see it around these apoptotic cells. We call that perivenular or pericellular fibrosis, otherwise known as chicken wire fibrosis, which is really common in non-alcoholic steatohepatitis. Now, as part of these dying hepatocytes, not only do they stimulate production of stimulate activation of stellate cells, they also recruit inflammatory cells, and those are what you see here. And these are lymphocytes and neutrophils that come into the liver and in response to this wound injury that's occurring. Now, just a little sidebar. The fibrosis that you see here in blue is actually a normal wound healing response to injury. You want that. You need that, particularly some of you that like to go out and drink on the weekends and you drink a little too much. You want to have a nice wound healing response to injury, because ultimately what that does is it allows a framework for new liver cells to be birthed and to grow. And once they're healthy and normal, that fibrosis gets reabsorbed through natural fibrinolytic processes in the liver. Where it goes awry is when you never take away the insult for injury. You continually drink alcohol. You get infected with hepatitis B or C. You have autoimmune hepatitis. Drug-induced liver injury. Tamoxifen is a great example. Valproic acid is another one. And methotrexate is another one. People that are consistently on those medicines in the right situation can lead to chronic liver injury, and that's where we see a setup where these stellate cells continually remain active and lay down scar tissue. So in the setting of fatty liver, what we're trying to do today is talk about how can we detect that fibrosis and how can we detect NASH non-invasively. Now, there are challenges with liver biopsy, as you guys know, so we definitely are looking for alternative non-invasive tests. We know these limitations and they're widely acknowledged. How common is a liver biopsy done today? Well, it depends on who you talk to. If you go to a barber, you get a haircut. If you come to Dr. Harrison's clinic, you're likely going to get a liver biopsy. However, if you go to a routine GI clinic or a primary care clinic, people look for every reason in the world to not do a liver biopsy. In fact, annually it's suggested that only about 60,000 liver biopsies are performed, despite the fact that over 64 million people are suspected to have fatty liver. So most are not diagnosed, and if found, are found too late. And I highlight this last phrase because when we get to the healthcare utilization data that was presented at AASLD, we're going to highlight the fact that when these people are found, they're found in a decompensated state. And we have to do a better job of finding these people before they get there. So, can we use LFTs to help us find these people? Well, the bottom line here is not really. Liver enzymes may be normal in up to 80% of people with fatty liver. Transaminases are not a sensitive test, and there's a poor correlation between ALT and histology. I direct your attention to the figure, the graph on the right. What you have here is ALT on the vertical axis and stage of fibrosis on the horizontal axis. And as you can see, ALT falls over time. Interestingly, what's not on here is if you were to juxtapose AST, it actually rises over time, such that by the time you're at bridging fibrosis, the AST to ALT ratio is 1. And that is an independent predictor of advanced liver disease. In fact, it's one of the best predictors that we have. So, there are a couple scoring systems that have been published in the literature and been validated in numerous situations, and we can use these. These are online calculators that people can use to help identify, or more appropriately, rule out patients with advanced liver disease due to NASH. One of these is the NAFLD activity score. The other is the FIB-4 score. Again, both have online calculators that you can use to help in your diagnostic algorithm. Now, what you see is that both of them have very good negative predictive values, between 90 and 95%. And that's if you use the lower cutoff for both of these tests. Now, at the higher cutoff, you see the positive predictive value for NAFLD fibrosis score being 82 to 90%. In fact, in other studies, it's not quite that high. It's more around 60 to 70%. And the same thing for the positive predictive value for FIB-4. But what you get in the center is a large group of people that are indeterminate. In fact, about 30% of patients will fall into this indeterminate category where we're not really sure what to do with them. So I think what I would say about this slide is that if you use this, this is a good tool to exclude people with NASH and F3-4 disease. It's not, however, a good tool to predict the probability that they have NASH with any stage of fibrosis. And then there's the indeterminate group in the middle that we don't know what to do with. So might I suggest that we consider alternative strategies and maybe additive strategies. And that's what we're going to focus on in the next several slides. So what about imaging? Well, we can use imaging to help us with steatosis, and there are two highly recognized modalities for that. One is the CAP, or Controlled Attenuation Parameter. That's part of the FibroScan technology, and we'll talk more about that in a bit. And then there's MRI-PDFF, which is now considered the gold standard for detecting fat in the liver. The issue is that it's a little bit more challenging to get MRIs in most of our clinics, and it's also quite expensive. Steatohepatitis, we're still trying to find a good modality to detect that non-invasively. There may be some light with liver multiscan, which is a multiparametric MRI that looks at corrected T1. There's some data to suggest that it may be pretty good at detecting steatohepatitis. And then fibrosis, we actually have several different technologies. Of course, FibroScan, or vibration-controlled transient elastography, RFE, real-time elastography, or what we call 2D shear wave, and then MR elastography. So let's focus on FibroScan. This measures both liver stiffness, which correlates with fibrosis, but also to some degree with inflammation, and then ultrasound attenuation rate, which is the CAP, which correlates to steatosis. Now, there are really three different flavors of this scanner that you can use. Kind of started with the 502 Touch, this stand-up unit, and then it kind of went to the one that looks like R2D2, and then there's the portable, what we call the 430 Mini, which, as you can see, is about the size of a laptop, and you can easily carry it around with you. Now, VCTE basically utilizes a 50 Hertz shear wave, and it generates about a 3 centimeter cubed area of liver tissue that gets evaluated. And basically, you put this transducer on the side of the liver, the right upper quadrant. It's targeting the right lobe of the liver. And you push this white button, and a little thump occurs that allows for this 50 Hertz shear wave to basically transduce through the liver. And we'll talk about what happens. But ultimately here, on this slide, you're measuring about 40 millimeters of liver tissue. It starts about 25 millimeters below the surface of the skin and goes to about 65 millimeters. So ultimately, the key is to ensure that you're in the liver when this transducer actually starts measuring the liver. It becomes a little bit complicated when you have a morbidly obese person where your skin surface to liver capsule edge is more than 25 millimeters. And I know that the company is working on some technology to help with that. But where is this test useful? And this is where I think, excuse me, this test is highly effective. And that is in ruling out people with fatty liver. So remember, 100 million Americans, give or take 10 million, have fatty liver. And the majority of them, 75 to 80%, have isolated steatosis, or NAFLD. They're going to grow old with their fatty liver. So we want a test that can exclude that 80% of patients. And I think this test has a high negative predictive value and does very good at excluding people with disease. Now, comparing this to FIB4 and NAFLD fibrosis score, if you were to look at this data set and say, okay, if you took a liver stiffness measurement less than 7.9 kPa, that ultimately you would detect people with less than F3 disease 97% of the time. And that is exactly what FIB4 and NAFLD fibrosis score does, is it excludes people with F3 and F4 disease with a high degree of accuracy and a high negative predictive value. So comparatively, this study does the same thing. This device does the same thing very, very well. The positive predictive value is good, but it's not great. So what I tell patients is if you have a positive FibroScan, it doesn't mean that you definitely have disease. It just means we need to do some additional testing. So what is that additional testing? Well, we'll show you in a minute what we think would be a good approach. But let's dive a little bit deeper into FibroScan and look at some of the published literature in the United States. Now, we've had data for a long time in Asia, even in Canada and in Europe, looking at the cutoffs for FibroScan, what works for Hep C, Hep B, what do we have for fatty liver. But I was really encouraged when we finally got some U.S. data on NAFLD patients. And what I highlight here is we're trying to distinguish F0 and 1 versus F1 to 4, which is really the patient population that we worry about. And if you look at the balance priority, this is what gives us the best sensitivity and specificity and positive and negative predictive values. 8.6 kPa tends to be the cut point. And this is exactly what I found in my San Antonio population that I talked about earlier, where we'd identified the prevalence of fatty liver and NASH. In my patient population, 8.5 was the cut point that distinguished NASH with some degree of fibrosis from those without. Now, moving onward, I think there's some more interesting data from this publication, and this is focused on cirrhotics. So F0 to 3 versus F4. And you see the ROC to detect F4 is 0.93. The balance priority cutoff is 13.1. Now, look at the positive and negative predictive value. The negative predictive value is 0.99, meaning that if a patient had a FibroScan of 13 or less, that we could exclude cirrhosis 99% of the time. That is the power of this test. The positive predictive value is only 0.39, meaning this patient may or may not have advanced liver disease. We just need to continue to evaluate the patient. And that's where the beauty, I think, of this test lies. Now, shifting gears to CAP, this is another measurement that you get through the exact same transducer, except this time it's looking for low ultrasound attenuation versus high ultrasound attenuation, and that gives us a low CAP value or a high CAP value, which correlates with steatosis. Now, people always ask me, what's the number? What's the CAP number where I can tell my patient they have fatty liver or not? Well, the best number to quote your patients is 280. Because this gives you the best sensitivity and specificity for detecting fatty liver. It doesn't absolutely mean that a patient doesn't have fatty liver if it's 270 or 260, and it doesn't mean that they absolutely have to have fatty liver if it's 290 or 300. This just gives us the best bell-shaped curve for what fatty liver would look like at 280. So this is what I use in my clinic to tell people that they are likely to have fatty liver or unlikely to have fatty liver. In fact, I can use it to help me, and I'll give you a case. So a lady I saw less than an hour ago, when I started seeing her a year ago, her CAP was 320, I believe. Today, it's 220. So it's dropped about 100 units. And she's also lost a significant amount of weight and has changed her lifestyle and increased her exercise. So I feel very confident in telling that lady that she now has gone from fatty liver to no fatty liver in 1 year period of time. So that's also very helpful for our patients. So I'm going to talk about a scoring system that is now known as FAST, which stands for FibroScan plus AST. And I'm going to talk to you about how combining FibroScan technology with a simple blood test that you get every day in your clinical practice can actually improve our diagnostic accuracy. So this study was presented at AASLD by Phil Newsome from the UK. And the context of this was really because there's a high screen failure rate in NASH treatment trials. We don't have a good way of identifying patients that are likely to wind up being treated with NASH therapies once they become FDA approved. So Echosens wanted to sponsor a study to try to improve on our diagnostic accuracy for this population. So what is this population? It's a population that's defined as patients having NASH with a NAFLD activity score of 4 or more, with F2 or with greater than or equal to F2 disease. So F2, F3, F4. And the study was done originally to design a test that would accurately show us who these people were, and then ultimately it was validated in a couple other data sets. So the score was developed using FibroScan VCTE and CAP, as well as AST and ALT. And it was done using a very rigid set of guidelines called tripod equator guidelines. And if you look that up, it basically is guidelines for using multivariate logistic regression analysis in designing and validating a clinical scoring system. So it's very rigid the way that this was done. It was internally validated using bootstrapping, and then it was externally validated in 3 different cohorts of patients. So when we originally the study was put together, the derivation cohort was from 7 British centers. Prospectively, patients underwent FibroScan within 2 weeks of a liver biopsy. The liver biopsy was read blindly by 2 expert hepatopathologists, and they used the FLIP algorithm to distinguish the different components of fatty liver, which is what we call the SAF scoring system, which is quite similar to the NAFLD activity score. So this just shows the study flow chart. Ultimately, 335 patients were used in the derivation cohort, and so I'll speak to that group of patients here. Ultimately, what was shown was that if you combine FibroScan plus CAP plus AST, you get an ROC of 0.83. If you were to look at FibroScan, CAP, and ALT, it wasn't as good. If you looked at FibroScan, CAP, and that AST-ALT ratio I was alluding to, it wasn't as good either. Now, down below, I think it's interesting to see what would happen if you just looked at FibroScan as a predictor, and you see the ROC is 0.75. If you just look at AST, it's 0.72. If you combine FibroScan and AST, it's 0.81. But if you combine FibroScan, CAP, and AST, you get to 0.83. So subsequently, that defines the new algorithm called FAST, FibroScan plus AST. Now, I talked about the derivation cohort. I just showed you that data. Now, how did it stack up in an Asian cohort of fatty liver patients, a U.S. cohort, and a French bariatric surgery cohort? And you see the numbers of patients in each cohort. And then down at the bottom, you see the numbers of patients in each cohort that actually met the definition that we were trying to get after with this diagnostic algorithm. So ultimately, this is a standard ROC curve, which shows 0.83, which is a very good test from a diagnostic performance perspective. When we look at different ways of analyzing the data, just like what was done with NAFLD fibrosis score and FIB4, it turns out that if you use 2 different cutoffs, one to define the optimal sensitivity and one to define the optimal specificity, you can actually improve the positive and negative predictive value of this test. So this is what the graph on the right shows. In black, you see sensitivity, and the best sensitivity is with a cut point of 0.4, and the best specificity in blue is with a cut point of 0.9. I'm sorry, 0.76. So ultimately, if you use this FAST score and you get a cutoff of 0.4, then you can feel confident with a sensitivity of 90% that you have excluded disease if it's less than that number. If it's greater than 0.76, the specificity is very high, and the positive predictive value is also very good in predicting the probability of having NASH with NAS of 4 with F2 or greater fibrosis. Now, again, I just wanted to show this data in a figure that represents, or in a table, that represents what the ROC was using VCTE+CAP+AST in the derivation population, in the internal validation population, in the Malaysian cohort, the U.S. screening cohort, and the French bariatric surgery cohort. So since most of us are in the U.S., I'm focusing on that in this box that's highlighted here. Ultimately, the ROC was 0.91, which is a very good test for picking up people with NASH, NAS of 4 with F2 or greater fibrosis. Now, If you look at our U.S. population and you apply the cutoff values, you again see a high negative predictive value for less than 0.4 and a high positive predictive value if it's greater than or equal to 0.76. Now, so you might say to yourself, how does that stack up to FIB-4 and NAFLD fibrosis score? Well, I'm glad you asked. In the top category is the FAST scoring system, and you see the ROC, the specificity and sensitivity, PPV and NPV. And as with any test that has optimized sensitivity and specificity, there's an indeterminate zone, or this gray zone. And about 12% of people using FAST fell into that. Now, comparatively, FIB-4 had an ROC of 0.69, and about 27% of people were in the indeterminate zone. With the NAFLD fibrosis score, about 42% of people were in the indeterminate zone, and the ROC was 0.7. So I think it compared very, very favorably to these two other algorithms. So ultimately, the conclusion was that when you combine AST with FibroScan, you can really begin to identify this at-risk group of patients. There's still some work that needs to be done relative to adding diabetes to see if that might improve the diagnostic accuracy of the test. Now, I'm going to shift gears and talk briefly about some of these healthcare utilization studies that were presented, because I think it's important to hone in on the health economics of this patient population. So just very quickly, the first abstract was a retrospective cohort study using medical and pharmacy claims data from this Optum research database. So 44 million patients were evaluated, and about 250,000 of them had fatty liver disease. And ultimately, patients were looked at from the first date of diagnosis of a more severe liver stage, and that was their index date, and then they followed them from pre-index to post-index. A better way to look at that is on this study schema slide. Patients were broken down into cryptogenic cirrhosis, and we looked at pre-index measures, comorbidities, healthcare resource utilization costs, pre-index, and then we looked at them post-index and compared. Same thing for decompensated cirrhosis. We looked at pre-index measures of healthcare utilization costs and then post-index measures. So very quickly, again, of those 44 million Americans, if you look at those with NAFLD and NASH, whether it was commercial or Medicare Part A, or Medicare Advantage Part D, 312,000 Americans were actually diagnosed with fatty liver. Now, this is what I was alluding to on the first slide about where the diagnosis gets made in Americans. It's not so much cryptogenic. Only 0.8 of the population evaluated had cryptogenic cirrhosis, but decompensated disease is where we saw most people popping up on the claims database, a little bit of liver cancer and a little bit of liver transplantation. It was the same for Medicare Advantage Part D. Majority of patients presented with decompensated liver disease. Now, if you looked at the total population, only 0.1% were diagnosed with NAFLD and NASH, but the problem is those 84% of them already had decompensated disease. What this tells me is we're not doing a good enough job of identifying these people early when we can impact their disease. If you look at the baseline characteristics, I think it's pretty typical of a population with advanced liver disease. Their mean age is in the 50s, and the majority of patients with cryptogenic cirrhosis tend to be female. However, by the time you get to decompensated disease, it's more 50-50. Men tend to have more liver cancer and undergo liver transplant more frequently. When we look at comorbid illnesses in these populations of patients, a couple things stand out. The prevalence of most comorbid conditions appears to increase with increasing severity of liver disease. And about 1/3 of patients across all liver stage cohorts had at least 3 or more comorbid conditions. That would include hypertension, diabetes, hyperlipidemia, and heart disease and/or renal impairment. So this is kind of the money shot, if you will, the cost of healthcare delivery. And ultimately, what we see is that from pre-index to post-index, the cost of healthcare delivery rapidly rises. If you were just looking at cirrhotic patients that haven't decompensated yet, over a 5-year period of time, the healthcare costs rise to about $134,000. If you look at decompensated liver disease, it's the same as liver cancer, essentially, at about $300,000. This is cumulative annual all-cause healthcare. And liver transplant obviously is at the highest. But even just overall NAFLD and NASH patients, you see a significant rise in healthcare delivery costs. So ultimately, a couple take-home points from this study, when you look at annual all-cause healthcare resource utilization, what you notice is the mean number of inpatient admissions and ambulatory visits increased significantly from pre-index to post-index across patients of all disease stages. And so I think what that tells me is that, again, we need to identify these people early on before they decompensate, develop liver cancer, and need a liver transplant. Now, the final abstract I wanted to share with you, and then we'll open this up for questions, is a real-world analysis of Medicare data looking at increased risk of mortality in patients with NAFLD and NASH. So again, this was a retrospective observational cohort study. A sample of 20% of U.S. Medicare patients were looked at, and it included NAFLD diagnosed patients with greater than or equal to 1 claim, and there were 5 different study cohorts, NAFLD and NASH only, those with compensated cirrhosis, those with decompensated cirrhosis, liver cancer, and liver transplant. Now, what you can see here is of the 10 million patients analyzed, about 250,000 had NAFLD and NASH. About 3,500 had cirrhosis, 71,000 were decompensated, 581 liver cancers, and 575 liver transplants. 2.4% of Medicare patients had NAFLD and NASH. And again, the telling truth here is at the time of first cirrhosis diagnosis, 93% already had decompensated. So this is a busy slide. I want to summarize it with just 2 points. Decompensated cirrhosis and liver cancer were significantly older than cryptogenic cirrhosis and NAFLD and NASH, on average about 4 to 5 years older. Across disease severity groups, patients were primarily white, and generally a higher proportion were female. Again, consistent with what we know, that as you ramp up in disease, you tend to have more females, despite the fact that fatty liver as a whole, males are more common. So then this just highlights when we look at comorbidities by disease severity, we see a very frequent number of patients with diabetes and heart disease, as well as hypertension. And consistent with the literature, if you look at NAFLD and NASH, about 20% of people have renal impairment. Cirrhotics, it rises to about 30%. Decompensated disease, about half. The same for liver cancer and liver transplantation. So renal impairment is actually a real problem in these patients. So what about survival analysis? This is a very classic Kaplan-Meier curve. And again, without any surprise, liver cancer tends to lead the way. That's the gray bar across the top, the gray line. But right behind that here, interestingly, is liver transplant and decompensated liver disease. About 50% of people will not survive past 8 years. But maybe just as importantly, if you just look at the black line, the NAFLD and NASH only group, by 4 years, all-cause mortality is about 7%, and this rises to almost 13% by year 8. So ultimately, the mortality rate is increased in NAFLD and NASH. It's about 26.3% in this study. Amongst NAFLD and NASH patients, it's about 12.7% in the general population. We know that NAFLD and NASH mortality increases with liver disease progression as well. This slide is just a very quick way of looking at adjusted hazard ratios for mortality. The red bars look at relative hazard ratios amongst the 4 different disease categories tested: cryptogenic cirrhosis, decompensated cirrhosis, liver cancer, and liver transplant. And on the right, you see those compared to compensated cirrhosis. Again, highlighting here that liver cancer stands out as being the greatest risk in this population. And I'll end with this slide. This is the cumulative incidence of liver disease progression. And on the blue line is probability of decompensated cirrhosis, liver cancer, and liver transplant in cryptogenic cirrhotic patients. On the vertical axis is progression in percentage, and on the horizontal axis is years of follow-up. And you can see that by 8 years of follow-up, about 45% of people basically in the cryptogenic cirrhotic group had progressed to one of these worsened stages. But if you look at the probability of developing cirrhosis amongst NAFLD-NASH patients in red, the stark reality is even 40% of those patients progressed over an 8-year period of follow-up. Again, I like to emphasize this is retrospective data, but I think the take-home point is that we're not doing a good job of recognizing patients early, and that's where I think this tool, FibroScan plus AST, can really improve our ability to non-invasively and relatively cheaply identify patients that are in the group that is likely to progress to worsening liver disease as illustrated on this graph over an 8-year period of time. So with that, I'd like to conclude. Thank you for your attention today. I know you guys all have very busy schedules, and I hope you found something useful in this presentation. Happy to answer any questions.
So, Dr. Harrison, thank you for that informative presentation, as always. We are now ready to transition to questions and answers. I wish to introduce Remco Inserink, the Director of Medical Affairs at Echosens North America. Remco has been monitoring the questions as they come in, and he will now read them to Dr. Harrison. Remco.
Thank you, Jerry, and thank you, Dr. Harrison, for that excellent presentation. And I'm sure it also took some effort to find some time in your busy schedule, so we appreciate it as well here. So I have been monitoring the questions, and there are actually quite a couple of questions. We don't necessarily have a hard stop at one, so I'll just continue to go, assuming, Dr. Harrison, that you would have the time. So I classified them basically in 4 categories. The first one around diabetes/obesity related questions, and one question from one of the physicians listening in obese patients with metabolic disease and NAFLD, does a 10% weight loss reduction resolve disease in most patients?
So the answer to that question is we think so. If you look at the data, whether it's data that we've generated here in Texas or data from Cuba, the Viller-Gomez paper was the most classic one recently published in Gastroenterology. 10% body weight loss actually affects improvement in fibrosis as well as NASH and the components of NASH. And we believe that to be true in subsets of people with diabetes and obesity as well. So it's still the foundational goal for every counseling that we do with patients with NASH is to set that goal at 10%. What we learned from the Viller-Gomez paper, however, is only 10% of people at 1 year are able to maintain that 10% weight loss. This is why you never see a reunion of the biggest loser, because they lose it, but then gain it all back. So it hits home the point that we have to continually reinforce good lifestyle habits in these people, even if they've achieved success by losing 10% or more of their body weight.
Thank you. Second question, more related to diabetes. So on one of your slides, I believe it was more in the beginning, you showed that diabetes seems to drive fibrosis. And the question basically was if the association has been proven causal, or that it's also possible that people with a high fibrosis state just more often exhibit coinciding but unrelated morbidity characteristics such as diabetes compared to people with a low fibrosis stage.
Yeah, that's a great question. You know, so everything that we present or that has been published is really cross-sectional. So it's hard to get at causality, what comes first, the chicken or the egg. But it's clear to me that diabetes is playing a role in disease progression. The degree to which it plays that role, I don't know. But I'm convinced that despite having solid data to support what I'm telling you now, I'm convinced that diabetes is a driver of fibrosis progression.
Okay, thank you. So sort of teeing off the diet and exercise question previously, now moving into the non-invasive technology question section. Question was, what is the purpose of performing any NIT for treatment selection if the answer pre or post result interpretation using that NIT will be the same without drugs today, meaning just do diet and do exercise?
Well, you know, that's the question that gets asked frequently, and I would say that we're in a rapidly evolving field, and just by being on the call today, you definitely have shown interest in this. So there are over 30 clinical, over 30 drugs in clinical trials for NASH right now, and all of them are going after this population of patients. There probably is a study that your patients could qualify for in the area that you are practicing medicine. But let's just throw that away and say you don't have any access to clinical trials. And by the way, there's some really good medicines being studied for NASH. I have the privilege of being on the forefront of a lot of these drug development, a lot of these drugs that are being developed, and there's some amazing data coming out. But if you don't have access to a trial, the guidance document that I was privileged to help write and publish in 2017 does highlight the fact that you can use vitamin E and you can use pioglitazone. Now, pioglitazone is a very good drug for non-alcoholic steatohepatitis. The data is overwhelmingly positive that it will work in NASH patients. The issue is it can cause weight gain and it can cause small bone fracture risk, and there's a black box warning with it. But in the right clinical setting, pioglitazone is actually a pretty darn good drug, but at least in the short term. Vitamin E can also be used at doses of 800 IUs or 1,000 IUs per day. Have to be a little cautious with that drug. It's never been studied in diabetics or cirrhotics. And there's also a bit of a risk of prostate cancer in men, although the number needed to treat is quite high. So there are options out there. It is important, even if you don't have therapy, to tell the patient their prognosis. So I get asked this all the time, and I tell patients, if you go to your gastroenterologist and they do a colonoscopy on you, find a mass in your colon and take a picture of it, but don't biopsy it, what did that do? Well, all that did was tell you you had a problem, but nobody knows how bad of a problem you had. The same thing with this. If we're not going to do liver biopsy, at least do a non-invasive test so that you can properly prognosticate your patient. When they come to your clinic, your patient wants you to tell them, Doc, how bad is it? What's my prognosis? You know, and if you do the test and you show that they have advanced liver disease, even if you don't offer them pioglitazone, vitamin E, or a clinical trial, it seems to me that if you shared with them that they had more advanced liver disease, they may be more aggressive in their lifestyle modification attempts. Or at least you can use that to your advantage to tell them that they need to. So that's how I would answer that one, Remco.
Excellent. Well, and just to tee off that a little bit, I think, the fact that there are no drugs today doesn't mean that there are no drugs in 2 years. So just identifying these patients today will probably help to more rapidly find those patients again in 2 years when you do have treatments available. So thank you. So another question, in your view, what process should be used to select patients for NAFLD screening in pharma trials today?
So again, I use FibroScan in every one of my patients. It's like a 6 vital sign. If it's less than 6, I tell them there's nothing to worry about. If it's between 6 and 8.4, we focus on diet and lifestyle modification. If it's greater than 8.5, that's the group I tend to refer on for clinical trials. I focus on patients with CAPs of greater than 280, and I look for patients that have an AST value greater than 20. The data that we've generated suggests that a CAP of greater than 280, a KPA greater than 8.5, greater than or equal to 8.5, and an AST greater than or equal to 20 actually identifies a group of patients that are very likely to have NASH with F2 to 3 fibrosis.
Okay, so that was a question basically related to NAFLD screening into pharma trials. So assuming that we will have treatments in the future, do you feel like NITs or NIT algorithms or step-based approaches are ready for prime time in the sense that once those drugs hit the market, they can be used separately from liver biopsy, and liver biopsy won't be necessary in those cases again?
I think we're making significant progress. I wouldn't say that it's ready for prime time just yet. I mean, the FDA has a very stringent biomarker qualification program, and to date, nothing has been FDA approved to diagnose patients that would qualify for treatment. I think we're making a lot of strides, and I think there are non-invasive tests out there that really help to at least put patients into buckets, those that we don't worry about, those that we kind of have a concern about, and those that we really have a concern about. And this will continue to be refined over the next year to year and a half. We're about a year out from having our first FDA-approved treatment for NASH, and so we still have some work to do, but I think we have time to figure that out. In the meantime, I would use potentially what I presented today as a way to stratify patients at risk.
Okay, thank you very much. So next question that I'll select, also looking at the time. So on the healthcare utilization that was presented at AASLD by you for the decompensated claim data group, did you have data available to assess which percentage of that group actually had an NIT performed previously before the decompensated state was diagnosed?
No, unfortunately, we didn't have access to that data.
Okay. Okay, so then basically, I'm just trying to scan. So one of the questions now, so this relates to biopsy, and this will be one of the last questions that I can ask. For biopsy, a physician mentioned, I have heard that liver biopsy is incorrect in about 15% of cases. Knowing that biopsy is actually the golden reference, what reference standard would be used in such studies to determine if the biopsy is right or wrong?
Mm-hmm. Now, there is no way to know. There's no single way to know. What I like to do is look at the compendium of data. So if I never look at a liver biopsy, kind of off by itself. I look at it with the liver enzymes. And really what I mean by that is look at the ratio. I showed you the slide earlier that ALT falls over time, AST rises over time. If you're looking at a patient that has an ALT that's 2 times that of the AST, the probability that that patient has advanced liver disease is pretty low. Alternatively, if the AST is higher than the ALT, the probability that they have advanced liver disease is very high if the patient's liver enzymes are abnormal. If they're normal, meaning they're both less than 20, you can't use that algorithm. But let's say they're both 60. The odds are that if your AST is 60 and your ALT is 60, that you have advanced liver disease. Then I would look at the liver biopsy. If the liver biopsy showed only stage 1 disease, and I'd be scratching my head, now I'm going to go look at the platelet count. If the platelet count is less than 150, that liver biopsy has a sampling variability problem. Now, you can confirm that with an MR elastography or even a FibroScan. If you have evidence of advanced liver disease there, then I would probably not go with the biopsy, and I would go with my non-invasive test. And the flip side of that is also true. So don't look at the biopsy alone. Look at it in connection with your clinical and non-invasive testing data. And really what you want with the biopsy is validation of your test. Now, if you're indeterminate, if you're in that indeterminate range, you kind of have to go with what the biopsy shows, and that's what I do in my practice.
Very good. So this concludes the amount of time we have for today's webinar. On behalf of Echosens North America, I would like to thank Dr. Harrison, Remco, and all participants for their interest in this topic. Good day to all.